Good day, viewers. I'm Isaac Akine, founder of Medical Student of the University of Lagos, and I have you with me.
Alakaloko Felix Medical Student of the University of Lagos.
I'm from the Surgical Interest Group Lagos, popularly known as SURGIL, a group of motivated medical students investing in priming, developing, and refining their interest in the beautiful art and science of surgery. Simply put, surgery serves to develop future generation of surgeons and
Join us today on this special series on surgical innovation. On today's episode, we'll be diving deep into the intricacies of an innovative surgical procedure, the first of its kind in any teaching hospital in Nigeria. Today we have with us Dr. Alakaloko, a consultant pediatric surgeon in Lagos University Teaching Hospital and a specialist in minimally invasive surgery.
Good, sir. It's a pleasure to have you with us.
Good morning.
Okay, so please can you tell us more about yourself? So, why surgery and how did you get to this stage in your career?
Okay, my name is Dr. Alakaloko Felix Makinde. Those are my full names. I'm a consultant pediatric surgeon and I work with the Lagos University Teaching Hospital. So back to your question, why surgery? Okay, surgery, is an act and also a discipline that, involves dexterity and activity. So I've been a restless person while in the medical school and I love to work with my hands. Okay, so, and I was fortunate to come across some great giants in the profession who were my mentors in my undergraduate school, who were very, very proficient surgeons, and I love their acts. So that motivated me to join the surgical field. That's why I'm a surgeon.
Amazing, sir. Amazing. Alright, so the thing is, most people think surgery is all about using a scalpel and causing harm to the patient. And so, please, can you tell us more about minimally invasive surgeries and how you got involved in this method?
Okay, minimally invasive surgery is an evolution in surgical practice. In the past, every surgical procedure is done open. Even till now, a lot of surgical procedures are still done open. But with innovations and development over the years, okay, we found out that you could actually do great extensive surgery with very minimal scar. Okay, and that's how development of endoscopic surgeries, laparoscopic surgeries, thoracoscopic surgeries came about. And of course, this has at the attendant benefit of limiting the disruption of tissues, trauma, elicited by the surgery, and so you have reduced metabolic response to trauma, and there is ultimately few or limited scars on the patient, and then early return back to work. Okay, so that's how it came about, and it has been on in gynecological field over the century, and of course general surgical field, and of course in the last 40 years it has come into pediatric surgery. We deal with miniature creatures, little children, and of course that requires more dexterity, but it's of proven benefits even to pediatrics, and that's where we are. So we are only catching up with the international world. It's been there and we are moving along with the international community.
So, can you tell us about the procedure you recently did?
Okay, so that was a thoracoscopic repair of tracheoesophageal fistula. Tracheoesophageal fistula just simply means that the patient was born without a connecting esophagus. The esophagus is atretic, and there's a communication between the trachea and the esophagus. So the patient is not able to swallow. If you understand, they have bubbling of saliva, drooling of saliva, excessive salivation, and even when you feed them, they choke on feed because of that abnormality. And it's one of the very stringent and difficult abnormality to deal with, because the children are just newborn and you have to feed them. Without food, they cannot live. Okay, so in the past, what we do for them is that we do what we call triple procedure. Okay, we divert their esophagus to the neck and then band their distal esophagus around the stomach and then put a feeding gastrostomy tube, and that will temporarily feed them until they grow older, about 1 year old, thereabout. Then we come and do an esophageal replacement for them. With that, we have condemned their esophagus. But over the years, we also do what we call primary repair for them. There are those that meet their criteria. So that means they're going to cut to the chest of through the chest of the patient, and then you ligate the fistula, and then you reconnect the esophageal ends and do an end-to-end anastomosis for them. And after that, you put a chest drain, and then you close the wound. Because of that large wound in the neonate, that usually has a turbulent post-operative period, okay? And of course, if you're able to pull through, the patient will do well, and the patient will feed after about a week when the anastomosis will have healed, and then the patient can be discharged home. But the advantage of minimal access over that is that such a baby can undergo such extensive surgery with very minimal tissue disruption. So there's minimal trauma, okay? There's magnification of the thorax of that patient, the hemithorax, the one-sided part of the thorax of that patient, and then you can use your minimal, tiny instruments that will go into the chest wall and do the suturing and do the ligation and do the, cutting. Everything that you do open will also be done minimally, and that was what we did for this index patient that we had.
So the patient is doing fine, right?
Our patient has come twice for follow-up in the clinic, gaining weight appropriately, feeding without any reflux, and the parents are happy and everybody is happy.
That's very nice.
Okay, so sir, the events leading up to the procedure, I read up it was a 13-day-old baby referred to LUTH, and given the nature of the surgery being a first-time procedure, were there any concerns you had, and what gave you the confidence to?
So actually, there were concerns, and that's with regards to the possible sequelae in such a patient. Of course, you know that when we go in for minimal access surgery, we counsel the parents and we take consent that if we are not able to proceed through the minimal access, then we can revert to open. So that was there, ab initio. And being the first of its kind, we have international and local colleagues who have been doing such. We interrelated with them and we had the discussions. And for this particular one, I had a colleague of mine who also does it in the private practice, Dr. Igwe, and he was around just to put us through, and that was it. So many of these innovations usually is made available through intercollegiate relationship and interpersonal, relationship. Apart from the fact that we are training it, I was in Israel for 1 year learning minimal access surgery, and we did quite a number there. Okay, but of course, ethically, that's not enough. When you have a patient, you have to do proper patient selection. Okay, and you must go for patients that have appropriate fitting to that setting, so that you don't unnecessarily incur negative outcome for yourself. So in this case, we selected the patient. We've had other patients, at least more than 4 other patients around that period that had similar conditions who we didn't do minimal access for because they did not meet the criteria. Just recently, I had a patient about 2 weeks ago that had similar condition. Patient was preterm, has had 2 episodes of apnea. Patient's weight was 1.5 and had aspiration pneumonitis before coming. The patient also had congenital heart defects, had a large PDA and the likes, you understand? So that's not the kind of patient you just pick and say, oh, because we have done one, let's go and do the second one. You understand what I mean? So we opted not to do minimal access for that patient, and we did the minimum, which is just a diversion, the triple procedure, and that's what we did for the patient. So that's it.
Is this procedure going to continue?
So the procedure has come to stay because it's of proven benefits to the patient by all standards. Okay, is now the standard of care in LUTH now, because LUTH has a facility to do this procedure and we have the personnel to do the procedure. Okay, we never had a dedicated pediatric laparoscopic tower up until January this year, and we never had pediatric working tools instrument, the tiny working instrument for laparoscopy, up until February this year. And 2 weeks after the instruments were assembled, we did this. So, and the instruments are still with us. So we were only we can only improve on that. So that's the beauty of having all these equipment. But they are very expensive equipment, so we can't really, blame the system. But federal government has done well. They have provided this for us, and we can only make use of them to the benefit of our patients.
Outside the operating room, what else do you do?
Oh, really? Well, I play lawn tennis. I go sometimes on hiking, bicycling, just take bicycle around, That's what I do around most of the time when I'm not in the theater or when I'm not in the hospital.
So soldiers are fun. Interesting facts.
Anyways, you call that fun? That's not. There are more funds that you can have as a surgeon. That's
Okay, sir. So now, sir, what advice do you give to students pursuing a career in surgery?
brilliant question. Okay, so my advice to children, the students that are coming into surgery is that one of the things that they should note is that surgery is an art. And if you are called out, to be a surgeon, you will know from within you because there will be that supposed to be, and it's fulfilling, gratifying, okay? And you just need to get appropriate mentors along the line who will guide you in all the steps so that you don't fall into some ditch that can be there. But I mean, it's a very rewarding field of specialization, and I encourage you to dream about it, think about it, and start early. And of course, identify mentors who can guide you along the path.
Thank you very much, sir. So, sir, if not surgery, what else would you have done?
Well, if not surgery, probably I will just be in community medicine. Yes.
And if not medicine?
If not medicine, I'll be an engineer. Because even as a surgeon, I take courses in engineering, even as a medical personnel. So I do courses in engineering. I do a bit of electrical engineering.
That explains your love for equipment and surgeries.
Yeah, it's something that will just drive you towards. You just want to fix things. You just want to be involved. Your hands wants to move. So if you have that passion, if you have that notion, that may be a pointer to the fact that because surgeons will work with our hands, okay, and with our brain, okay. So that's how it goes.
Okay, so how do you manage the balance between work and your personal life as a surgeon?
That is tedious, okay, especially in the field of pediatric surgery, okay, but you still have to strike a balance. Family life, the work environment, and other social activities, okay. So a complete man is not someone that is focused only on one aspect of life. A balanced man is someone that goes around and is fulfilled, fruitful in all the other spheres of life. So we try as much as possible I try to put in my best and my all to my work. There's a principle of all or none, okay? And when I'm outside work, I don't think about work. So when I get to my home, I don't think about work. I remove my mind away from work and I'm at home. Home is now home. And when I'm at home, and when I'm at work, I don't think about home. And then when I see that I'm becoming fatigued, either from work or I try to get myself a place to just chill out and relax. Then in that way you can recalibrate. Sometimes I take 2 days off and just run away from Lagos State and just go and be somewhere, sleep and just sleep, wake, and with that you can recalibrate because you can actually work yourself to death with pediatrics because it's unending. The patients keeps coming, they will never finish and you will keep on working. So if you work yourself to death, the work will continue outside you. So you must find a balance so that you become refreshed all the time. So that's the way it goes.
Interesting principles are all on one. Thank you very much. So also, what qualities or skills do you believe are essential for a successful surgeon? Qualities or skills?
Well, as a surgeon, you have to be disciplined. Discipline is the watchword, and discipline entails that you do things, the principles of doing things the way they ought to be done, repeatedly, recurrently, all the time. So you have to learn to be disciplined. There's a time to do this, there's a time to wake up, there's a time to put this into order, there's a time to, you have to just organize your way, your life, and then organize your activities. Then for every surgery that we do, you don't come with a bold face of, I've done it before, I've done several, I can do it. You have to rehearse, you have to revise, because you are dealing with human beings. There was a statement that I always hold on to. It says, a good surgeon knows how to operate. The better surgeon knows when to operate. The best surgeon knows when not to operate. And you can only get that best by discipline. So the principle of discipline cannot be overemphasized for you. And as you go on, you have to also be dynamic, because new things are evolving, new principles, new techniques, and you have to be dynamic. You have to change. Change is the most constant thing in life. Okay? And if you don't change, you become obsolete. And that's the end. So you have to also be dynamic to be able to learn new things. And as you learn those new things and you are disciplined, the sky is the limit for you as a surgeon.
Sir, can you describe a typical day in the life of a pediatric surgeon?
A typical day in the life of a pediatric surgeon starts from 5 a.m. Let's say that 5 a.m. you're up to do your normal daily chores, and then I'm at work by 7:30 a.m. So I leave home, get the children to school, and then by 7:30 you're in the hospital, and the round starts by 8. Okay? During the round or after the round, you may have 1 or 2 patients to attend to, and then from there you go to theater. You have cases to do, maybe 2 or 3 cases for that day. You do those cases, and then in the afternoon you do school runs, take the children back from school back home, and then you are still in the hospital following up those patients we have operated and reviewing new patients that you are going to operate either later in the day or the following day, because I told you it's a conveyor belt and the patient load is quite high here, especially for pediatric surgery. At least on the average, you operate minimum of 2 patients every day. So you get to get your hands really dirty, really dirty. Okay, so you do that, and then as you are preparing, you are also monitoring and you are overseeing other patients that may also need your attention. And then by evening, the work day closes by 5, but for a pediatric surgeon, your day does not close. Okay, so even when you are at home, you have to leave your phone open, because there may be situations that warrant your presence. So you come back and sort them out and you go. But the good thing is that you derive pleasure in doing these things because you save a lot of life by your knowledge. Okay, and it's not that bad that you will not have any life for yourself. It's just that in the initial period it's quite demanding. It requires your attention, requires your being present. Okay, and that is what makes the difference for the patient, because you're present and your decision just in one spot can save the life of a patient just because of your knowledge base. But if you relent on that and you are just absent from work, then all you hear is demise, and that's not fantastic. Okay, so by evening I'm back home and I'm back with my family, and life continues. The following day, the same sequence, just like that, day in, day out, including weekends.
Yes, sir. Sir, where do you see pediatric surgery in 10 years?
Pediatric surgery is really advancing, and in the next 10 years, I see us using Da Vinci robots to do some of our surgeries, even in Nigeria. It may sound very highfalutin, but it's not, because these things are there to stay, and the world is a global village. Things are evolving, and we have young minds like you who will build the carts. You take the frontiers and you will do these things, and they are available, they are doable. And in the next 10 years, I see, because many of the things that we do now, they are at par with what our colleagues do in the international community. Okay, except for those things that require high-tech equipment that we don't have. But Nigeria is coming of age, and a lot of private sector driven investments are coming into the health sector now that we make these things available. So I see us doing everything that is doable. Now, for instance, in Nigeria, we don't have any pediatric transplantation program, both for liver and for kidneys. Okay? But if you just heard, yesterday, the first pig to human kidney transplanted patient was discharged from the hospital. You understand? At in the US, Massachusetts hospital. Okay, first pig to man transplantation that was successful. Patient was transplanted about 3 weeks ago, and he has been discharged now. And patient is not on the dialysis again. So these innovations are going to come to Nigeria. As we speak today, now there is no center that does dedicated pediatric liver transplantation or kidney transplantation in Nigeria. So I see in the next 10 years, we'll do that. And then we'll do other greater things. That's my belief and my resolve.
And thank you all for watching also.
Okay. I hope you come and join us in pediatric surgery.
Good day, viewers. I'm Isaac Akele, founder of medical student of the University of Lagos, and I'm having you.
Alakaloko, founder of medical student of the University of Lagos. On today's episode, we'll be diving deep into the intricacies of an innovative surgical procedure, the first of its kind in any teaching hospital in Nigeria.
My name is Dr Alakaloko Felix Makinde. Those are my full names. I'm a consultant pediatric surgeon, and I work with the Lagos University Teaching Hospital. Sometimes I take 2 days off and just run away from Lagos State and just go and somewhere, sleep, and just wake, and with that you can recalibrate, because you can actually work yourself to death. You know, there was a statement that I always hold on to. It says a good surgeon knows how to operate. The better surgeon knows when to operate. The best surgeon knows when not to operate.